morning, everyone. Thank you for being here this morning. I just want to extend a thank you to Crystal and the organizers for allowing me the opportunity to participate in this conference with you. Today, we're going to be talking about percutaneous placement of PD catheters. And I'd like to start because, as many of you are aware, about a year or so ago, President Trump signed an executive order to launch Advancing American Kidney Health. This kidney care health executive order was put in place to advance many of the initiatives that we have been touting for years to help improve kidney health in this country. Where, as many of you are aware, much of the Medicare dollars are spent dealing with kidney disease in this country. So this initiative had several goals that were very important. The first goal was to reduce the number of Americans developing end-stage renal disease by 25% by 2030. The second goal was to improve person-centered treatment by 2025, and that was to really focus in on 80% of new ESRD patients receiving home dialysis or transplant. The third goal was to increase access to kidney transplant, doubling the number of kidneys available by 2030. Now, these goals are very lofty and will take a concerted effort by all players to be able to make sure that this happens. Today, we'll focus a little bit on the second of these goals because it really is something that we have to address when it comes to home dialysis therapies. As many of you know, home dialysis is growing in the United States, but it only represents about 12% of all dialysis patients. When you look at the prevalent US home dialysis population back in 2017, you had about 62,000 patients that were considered home dialysis patients. Of those, only 10% of the total dialysis population was peritoneal dialysis. And even though we've had growth of about 50% in both the home HD as well as the peritoneal dialysis population, we're still just a small fraction of the total number of dialysis patients throughout the country. So this has to be addressed because we know that there are several advantages for peritoneal dialysis. Nephrologists all across the board acknowledge that there's an important role for home therapies, mostly because of the outcomes. 76% of US patients are medically eligible for PD. Interestingly, when I was in fellowship, it used to be the thought that PD was really for the most able-bodied patients with young working patients who had great hand-eye coordination and good manual dexterity, and there had to be all these optimal conditions for a person to be an eligible candidate for PD, when in fact, there are many people who are eligible candidates for PD that we have ignored over the time and haven't given a fair chance to give it a try. Nephrologists feel that 30 to 37% of patients should be on PD. So if you were to look at an ideal mix of modalities throughout the country, we'd like to be able to see that in-center was 50% or so, PD was about a third, and home dialysis was the rest, home HD was the rest. And so peritoneal dialysis should take up a larger percentage of our dialysis patients, but for a number of reasons, that is not the case. And it's a shame because there's several advantages over hemodialysis, although it's the modality we're most comfortable with. With peritoneal dialysis, we know that you can maintain the residual renal function, which makes it much easier to manage patients as far as their blood pressure, their weight, and other aspects of their overall care. In addition, we see that there's lower mortality in the first year. And over the last 30 years, as you can see in the graph to the left, the mortality rate in the first year has dropped precipitously over the last 30 years, so that the first year mortality rate now is much less than hemodialysis, and that is statistically significant in many studies and is borne out in the US RDS. In addition, the quality of life for patients on peritoneal dialysis seems to be better. And when you ask them, what kind of things are important to them, they talk about mobility, independence, autonomy, simplicity and convenience, and the ability to control their own destiny. And certainly liberalized diet comes to play for many of our patients. So this is what they say, but what the numbers say is that the cost is actually a lot better for peritoneal dialysis over hemodialysis. When you look at the graph to the right, you notice that in the turquoise color is the hemodialysis cost, and that's the highest cost of all different modalities, including peritoneal dialysis and transplant. So peritoneal dialysis is a much reduced cost over time, mostly because of the decreased hospitalizations that happen for peritoneal dialysis patients compared to hemodialysis patients. And so cost is another factor that we have to consider. Now, the question would then be raised, well, why is it the case that peritoneal dialysis is not as popular compared to hemodialysis? Well, there are some disadvantages, and it was with every modality that we could consider and every treatment we can consider for our patients, there are pros and cons, and all of those we have to address, present to the patient in totality so that they can make an informed decision. So the potential PD disadvantages include these. Number one, infection, and this is the one that scares people the most, peritonitis, which can be deadly, frankly. Certainly exit site infections in the tunnel or at the exit site itself. Hypotension is a problem as people have a lot of protein loss with the effluent and peritoneal dialysis and can have decreased oncotic pressure and problems with low blood pressure and the symptoms thereof. Certainly protein malnutrition can happen, although it's not as common, especially with those patients who are in an inflammatory state, whether it would be diabetes or other conditions. And certainly catheter dysfunction, having issues with the catheter that requires intervention, that can be a point of frustration and one disadvantage that patients will tell you. So these are the kind of disadvantages one could see in peritoneal dialysis, but as you know, we have disadvantages for hemodialysis as well. When you look at patients who are on peritoneal dialysis after a full year, the question is, well, how are they doing? Well, 2/3 of them are still on PD and thriving with it. Some have had transplant, which is a good thing, so we consider that a positive outcome. And then we have hemodialysis transfer, those who weren't able to continue peritoneal dialysis and have transitioned either back to hemodialysis or to hemodialysis. And of course, you have those who have survived the year. And this is one of those things that has still been a thorn in the side of all of us in the dialysis world, that we have a pretty robust attrition rate, people dying within a year being on hemodialysis or even peritoneal dialysis. But in comparison, actually, the death rate is actually a little bit less with peritoneal dialysis. One of the reasons why peritoneal dialysis patients have a difficult time is because the catheters are part of the issue for many of our patients. When you look at the history of peritoneal dialysis catheters, and I'm not sure if many of you are aware of it, this comes from a lot of trial and error and a lot of issues along the way. When you go back to 1926, the first PD catheters, if you can ever imagine, was this stainless steel catheter that was developed by Dr. Stephen Rozenak. And this catheter was used for continuous peritoneal lavage. Once again, it was stainless steel and it was complicated by frequent peritonitis. As you can imagine, this kind of catheter was just straight into the peritoneal cavity. It was a very difficult time having a seal. It was only used temporarily and removed temporarily. But if you can remember, this is 1926. So penicillin wasn't even discovered yet. It was discovered in 1928 in London. And so treating infections was still a novel endeavor at the time. So one could surmise that even a catheter like ones we use today would have been difficult to use without having the right kind of treatment for a possible infection. So the first hemodialysis was successfully done in 1945, and around that same time, others were inspired, Dr. Kopp specifically, to develop a peritoneal dialysis modality that would be safe and reproducible for patients. They used a gravity-fill system that had porcelain containers for sterilization, and he treated 21 patients, 10 successfully, others didn't do well because of infectious issues. Other groups like the Beth Israel Hospital group used a 2-catheter system to minimize outflow obstruction. As you can see by the image next to this presentation, you see that there is these porcelain containers on a pedestal that's being used to fill and to drain for people who are trying to use this closed system peritoneal dialysis with the 2 catheters. Then Russell, Palmer, and Quinton found that the silicone material was better for catheters and could reliably be used in patients and was safer. It didn't have as much of an inflammatory reaction. The catheter infection rates were much less. And this was first developed in 1964 and was utilized. You can see it has a pigtail end to it that we are using today. And then later on, Tenkov, who was catheters that we use today is really named after him, used a double cuff catheter with a pigtail tip that allowed for continuous indwelling placement. And these felt cuffs were sealing the openings so that it kept them from having leaks or from having infections. And he developed an insertion tool or trocar for easy placement so that they could be placed right into the peritoneal cavity. And at this time, surgical placement was the rule of the day. And so even now, when we consider putting in a catheter, we have to consider our type of catheter placement options to make sure that we employ the right type of approach for our patients depending on what their circumstances are. So now we have basically two different placement options for our patients. And that falls under two categories. First, surgical category, and that's been done the longest. And second, the percutaneous category, which is now employed mostly by interventionalists, nephrologists, interventional radiologists, and others, for a host of reasons, which we'll review in just a moment. The two surgical methods are the open and the laparoscopic. Open is just as described, which requires a laparotomy, where you open the abdomen, get into the peritoneal space, place the catheter, and suture it in place, and get everything sewed up. Patient has recovery time to deal with and contend with, and then there's a period of time of healing until the catheter can be used. Laparoscopic adds another wrinkle in that it's less open, it's less invasive, and uses the laparoscopic technique for placement. It has some advantages, which we'll discuss shortly, as far as addressing any kind of abdominal anatomical issues that a patient can have. Then we have the two percutaneous methods. One is a peritoneal scope, which is a rigid type of scope that is utilized to be able to see inside the abdominal cavity, to understand exactly where the placement is and be a little bit more precise with placements, much like the laparoscopic technique. This has fallen out of favor because of complications and other reasons, and so this is not routinely done any longer. The fluoroscopic technique utilizes some of the technology we use for other modalities, and so we use ultrasound to be able to see exactly where we're going, and then fluoroscopy, which is a live X-ray type of technology to be able to see exactly where the catheter is placed in relation to other organs and to the cavity itself. So we'll go over this just in a few moments. So the question is, well, which one's better? And it depends on who you ask. I'm sure if you ask a surgeon, they'll say surgical. If you ask a non-surgeon, they'll say non-surgical. But let's look at the data. When you look at a meta-analysis from 2013, this meta-analysis looked at laparoscopic versus open and analyzed what kind of complications one would see in the intervention or replacement or revision category or in the removal category. And what they found was that by and large, there were less events or untoward events or complications in the laparoscopic versus open category. This didn't say anything about function of the catheter or whether there was good longevity of the catheter. It just talked about the kind of complications one would expect from a surgical procedure, and found that the laparoscopic seemed to be safer. Up to this point, most studies pointed to equivalence when it came to function of the catheter in laparoscopic versus open. So finding a safer and less complicated way to place the catheters with patients having less complications, at least in the perioperative period, was a big success at the time to be able to point patients in that direction. But as we start to consider percutaneous placement, the question is, how does it compare to either laparoscopic or open? Well, there was a nice meta-analysis as well in 2015, looking at 13 studies comparing percutaneous to surgical, and these were specifically laparoscopic. And in this, there was 2,681 adult subjects, and they analyzed 4 different aspects of catheters. First, 1-year catheter survival. 2, catheter dysfunction. 3, fluid leak. And 4, peritonitis. And first, here we have 1-year catheter survival, and there's pretty much close equivalence there. There was a very slight favor for percutaneous placement, but not enough to be statistically significant. So there's a mild favorability for 1-year catheter survival in percutaneous, but not enough to sway our decision-making. The second was PD catheter function. So as far as dysfunction is concerned, largely equivalent. Not much difference in the way of comparing percutaneous versus surgical. And then looking at associated leak, catheter-associated leak, I should say, once again, pretty much right down the middle when you compare all 13 studies. Where there was a little bit of a divergence was when you got to PD catheter-associated peritonitis. So peritonitis seemed to be better in the percutaneous group versus the surgical. And almost, I guess I would say 10 of those studies really demonstrated a strong favorability for percutaneous approach. Once again, there are conditions in which one would choose one modality over the other depending on the patient's situation. But it helps us to understand that not only is percutaneous approach to placement of the catheter safe for patients, but has some advantages in specific situations. And certainly infection is one of those advantages. So when we consider the PD catheter insertion procedures in total, it's important that the type of procedure that you're going to suggest for your patients is understood as a key factor in the risk of early infections. So it's important, as we saw here in this meta-analysis, that maybe percutaneous has some advantages. And while the catheter type, what type of catheter, what company you use, whatever catheter production that you are preferring, has not been linked to risk of complications, certainly improper insertion may increase the risk of complications. So it's important to find someone who has a lot of experience and comfort in placing these catheters and has a track record of no complications or a low risk of complications. With ultrasound and fluoroscopic guidance, percutaneous insertion is a reasonable alternative to surgical placement. Certainly one that can be done sometimes a little bit quicker because of not having the hurdles to jump through as oftentimes they're seen in the hospital in the OR setting. Laparoscopic is preferred over the open surgical approach as it permits proactive techniques such as selective omentopexy and adhesiolysis with shorter recovery, and certainly preferred over the percutaneous for the same reasons. These are issues where patients have problems with their omentum and have adhesions from prior surgeries or other inflammatory conditions in which there is a lot of scar tissue and adhesions, and that can be taken care of very easily with laparoscopic approach that cannot be done in the percutaneous approach at all. Similar technical outcomes and patency rates for percutaneous insertion with ultrasound and fluoroscopic guidance compare favorably to laparoscopy, as I mentioned in our meta-analysis. So once again, with percutaneous PD catheter, we have some pros and cons. We have the advantages that can be performed in radiology and not in the OR, and even can be performed at the bedside in situations where ultrasound is available, but fluoroscopy is not. It's least invasive with a reduced recovery time. Patients can actually use these catheters as soon as 24 to 48 hours after placement, as opposed to having to wait for several weeks in the open and sometimes in the laparoscopic approach. Minimal sedation is required. Ultrasound guidance for needle placement reduces risk of bowel perforation. And indeed, bowel perforation is a very, very minimal risk in the percutaneous approach. The disadvantages that I mentioned earlier is an ability to perform other surgical interventions. You can't do omentopexy, you can't do adhesiolysis with percutaneous catheter placement. In addition, there's no direct visualization of the abdomen in high-risk patients or those with prior significant abdominal surgery. Largely, the procedure is blind, and even though you're using ultrasound, you can't see some of the pitfalls one can discover in laparoscopic or open techniques. Although these advantages or disadvantages are the ones in which we often quibble about, COVID-19 happened early this year and made us change our vantage point when it comes to percutaneous placement. As you know, many patients were in the hospital suffering with the ravages of COVID-19. And because of the critical ill status of many of these patients, acute kidney injury was an issue. And so COVID-19 related renal replacement therapy became an often topic of discussion. Hemodialysis was given for the hemodynamically stable. CRRT or CVVH was given for the hemodynamically unstable. But the problem was the resources started to run rather thin, and many hospitals had to turn to other modalities because rationing hemodialysis and CRT was becoming untenable. So acute PD, initiation of PD for acute kidney injury within 48 to 72 hours after catheter placement, or urgent start PD for patients who already had advanced CKD and we knew that they needed to have support, was what was done. And so acute PD or PD catheter placement was coming to the fore, and elective surgeries weren't allowed as readily. Therefore, percutaneous placement was another option that even surgeons were calling us for help to get started on. So for the last 10 minutes, I'd like to just focus in on our percutaneous PD catheter placement as a technique. It's a implantation technique that requires local expertise. You need an access facility and a team that knows what they're doing when it comes to placing these catheters. They should have a dedicated team for PD catheter implantation, and the facility should have all the appropriate support to be able to do so. You have to have clinicians who are trained specifically in placing these catheters. They should be performed by these trained individuals, and really you should avoid inexperienced or unsupervised operators. In our company, we have a training process that allows for supervised placement over time until a person is fully prepared to do that on their own. An audit should always happen to make sure that the PD catheter insertion outcomes are what one would expect on a regular basis. When placing the percutaneous approach, the inclusion and exclusion criteria is important. Number one, inclusion, although it can include most ESRD patients, it's important to recognize ones that would not be included. It turns out that some high-risk surgical candidates are very appropriate for percutaneous placement because they don't require general anesthesia, certainly don't require some of the concerns that one would expect to have in the OR. If they've had failed cardiac or anesthesia clearance, they certainly can have a percutaneous. And just a few months ago, I had to place a catheter on a person who had pulmonary hypertension and was a brittle cardiac risk for OR placement. And so we were able to place it safely for him, and he's doing well on PD now. And certainly for emergent or urgent start PD, percutaneous approach can be very helpful. But if the person has had a major abdominal surgery in the past and you're concerned about adhesions and other kind of scarring, or you tried to place it in the past and there was a lot of loculations and you couldn't get the catheter in place, surgical approach is better. If they have an abdominal hernia or previous peritonitis, one would be concerned about scar tissue that would make it impossible. And certainly in polycystic kidney disease, given the mass effects of the polycystic kidneys, percutaneous approach is definitely not what you would want. So pre-procedure, we have an initial consultation. We make sure we educate the patient on PD catheter placement so that they can have all their questions answered and know what they're getting into. We have a detailed history and physical, and of course an abdominal ultrasound to make sure that the abdominal wall architecture is acceptable for the patient to have the percutaneous placement. We schedule the procedure often within 24 hours, but certainly within the week. We have a preoperative bowel prep, which is helpful but not required, helping to kind of decompress the bowels so that we have a lower risk of perforation. And then on the procedure day, we repeat the physical exam and ultrasound, place a peripheral IV for IV antibiotics and constant sedation if necessary. There are times when patients would prefer not to have that. And then we go for it. So the catheter is placed with the internal segment placed with the pigtail fenestrated loop, and then the catheter is tunneled out the skin so that the patient can use it. Here's a schematic of the ultrasound showing the rectus muscle and the rectus sheath and the peritoneal cavity, the arrow showing where we enter to get the catheter in place. So when we place the catheter, we have to consider multiple factors. First, the body habitus, how large the patient is, where their belt line is, because this can vary greatly even for the same size patient, whether there are surgical scars or hernias or stomas that can tell us that we're going to be in trouble placing it in a percutaneous fashion. Whether the person is incontinent, so we want to make sure we tunnel away from the lower abdomen. If they've had a transplant before, you want to place on the contralateral side of the transplant for obvious reasons. And of course, patient preferences as far as where the exit site can be, from anywhere from the mid-abdomen all the way to the peristernal area. You want to examine the patient both sitting and recumbent to make sure that the exit site is appropriate for them. And then you want to determine the incision site and the entry point based on where the pigtail of the catheter is going to sit you know, right above the pubic symphysis is where the top portion of the pigtail is going to be placed. This is a typical type of catheter. It's a double cuff catheter, one for the rectus muscle and one for the tunnel. And then the swan neck is not necessary, but it's certainly helpful. Oftentimes the catheters are pliable enough that they can be placed in any configuration that you like. The pigtail is important because it helps for fluid transfer. 15 French is the standard diameter, and there's about 20 centimeters worth of fenestrated or small holes along the distal portion of the catheter allow for good fluid transfer. This is what the abdomen looks like in ultrasound, so we can know where the skin, the subcutaneous tissue, where the muscle itself is, the anterior rectus sheath, posterior rectus sheath, and of course the parietal peritoneum, and then the intra-abdominal cavity where we see the bowel and those structures. It's important to see all of that before we get started to know there aren't any culprit vessels like the inferior epigastric arteries that could be in the way where we can, you know, have a bleeding complication if we're not careful. So the actual procedure itself, once the patient's in place, they have their IVs in place, they're ready to go. We, you know, anesthetize the entire area, the surgical site, and we anesthetize the skin. We do our abdominal incision first. It's only about 2 centimeters to 3 centimeters in length. And then we dissect down to the rectus muscle, and we enter the peritoneal cavity using a needle under ultrasound guidance, and using Sullinger technique, we advance a wire in. And once we exchange a needle for a coaxial dilator, which is a flexible long catheter, we're able to put a contrast in to make sure that we're in the right place. We want to make sure that our catheter is in the intraperitoneal cavity. We want to see diffusion of contrast into the intraperitoneal cavity. You don't want to see it in the pre-peritoneum or in the bowel, God forbid. It's most important to make sure that your position is correct. And then we insert a guide wire which loops down into the peritoneal cavity behind the bladder, and we're able to see the contrast layer there appropriately. And then we take that little coaxial dilator out, put a peel-away sheath, which is our entry conduit for a catheter. And once that's in place, under ultrasound guidance and fluoroscopy assistance, we're able to insert the catheter through that sheath, and it splits in two, and we can remove the sheath while the catheter stays in place, and we can place that deep cuff at the rectus muscle. Now, we don't typically bury it into the rectus muscle, but we place it at the rectus muscle and secure it with our suturing, and I've never had a leak doing it that way. Over the last, I guess about 9 years we've been doing this. And so once we've confirmed, we once again do another peritoneogram so that we can see where the contrast is layering around the pigtail. And once we've confirmed that, we test the catheter for bidirectional flow, saline going in, saline coming out. We usually put about 200 to 300 cc's of saline in to make sure the catheter sits appropriately in the right place and doesn't migrate for us. And then we back tunnel the remaining part of the catheter through the skin, burying the superficial cuff into the subcutaneous tissue. And then we suture close the incision using subcuticular closure so that there's no suture visible, and that's absorbable so that nothing will have to be removed later. And then put the dressing on, and we're done. And this is all it takes, and it's a pretty straightforward procedure that takes about 20 minutes to 30 minutes or so. And in this study, you can see that percutaneous insertion is pretty standard and easy to do, has a short time frame, it's a high success rate, no bowel perforations or hemorrhage. And although this study showed some initial problems with drainage in about 12%, it compared favorably to what the laparoscopic and surgical approaches are seen. So the complications are minimum, and with catheter survival at 95% in 6 months and almost 88% within a year. So in summary, the percutaneous PD catheter placement is safe, it's minimally invasive, it can be done in the interventional radiology suite or at the bedside. It's certainly done in the outpatient setting. It doesn't require general anesthesia. Conscious sedation is helpful. And it has less peritonitis as compared to the laparoscopic techniques as shown in our meta-analysis. And it's optimal for acute and urgent PD. I certainly suggest that you consider it for your patients because it's something that allows them to be able to get it in a timely fashion and in a very safe and appropriate way. But thank you for your time and attention. I'm glad that you were able to join us to discuss a little bit about what percutaneous PD catheter placement is all about. If you have any further questions, we'll be able to address it in the Q&A period. I thank you, the organizers, again for including me in this discussion, and I hope that you enjoy the rest of the conference. Thank you very much.